if you have it ready to go, that'd be fabulous. Or I can grab it. You got it for me? Cool. Do I need to claim co-host?
Sorry, you should be good. You should be able to share.
Okay. I have to. Do you have it pulled up by chance? I can grab it really fast. I confess I was more concerned about getting myself logged in on time than having this pulled up and kind of spaced it. But I can grab it really fast. I have it now. Yeah, I have it now. Oh, you got it now. All right, excellent. Thank you. All right, caring for our patients during a pandemic, opioid use disorder patients. I think we all probably know what pandemic I'm talking about, but H1N1 is not the one I'm talking about. I don't know why that just came to my head. I've been thinking about it lately. That was our last pandemic. The one we're currently talking about is coronavirus. I want it to go away so much. I'm trying to forget it exists. Brian, I can't advance the slide, so can you advance for me? Thank you. I don't have any disclosures. Next slide. So basically, I want to demonstrate how the current pandemic, the infectious pandemic, is worsening the epidemic that we have with opioid use disorder. Look over some emerging data and then sharing ways, and actually this will be a little bit interactive at the end of my presentation, sharing ways to connect with people who are needing care. Next slide. So essentially, when you take substance use disorder, opioid use disorder, and combine it with SARS-CoV-2, it results in a double whammy none of us want. One in and of it by itself is enough, but you put the two together and it gets particularly complicated. Next slide, please. The slides that we always get to see and love, looking at what the epidemic is doing as far as like the number of overdose death rates, because that's sort of a reflection, right, of how many people are actually using substances. The people who have an unfortunate event with a substance that results in their demise can very definitely reflect on the number of people who are using. We have statistics that I didn't pull in here that we've seen in other presentations about, you know, the estimations of who all is using and using what in the United States. But these curves look familiar, I do not doubt, because you guys get to see these in a lot of different presentations. But one of the things we've definitely been commenting on a lot here lately is since around 2015, the astronomical rise in the synthetic opioids other than methadone that we're seeing people overdose from. So that's the bottom graph there. And then just also recognizing that we should not overlook our stimulants, because we're definitely seeing an increase in overdose related to stimulants as well. Next slide, Brian. So when we think about general population compared to our population that has a diagnosis of a substance use disorder, opioid use disorder, there are some commonalities amongst those with a substance use disorder compared to the general population, such as higher burden of comorbid medical conditions, experience social and economic disadvantage, homelessness or residential instability, imprisonment, transportation issues, barriers to accessing healthcare services. Some of those things like homelessness and economic disadvantage, being sick, too sick to come to the doctor, all those are things that can keep people out of our offices. But one of the big things that keeps people out of our office is the feeling that they're going to be judged, discriminated against because of what their medical condition is with the substance use disorder. Next slide, please. So when you take the epidemic of opioid use disorder, substance use disorder, and smash it up against the pandemic of the SARS-CoV-2, it makes everything more challenging. Those with severe substance use disorder may have issues where you don't know where someone is at a given point in time. Being able to track your patients down is difficult. So if they're rotating between facilities, they're surfing different couches, they're in this town and that town, or just not wanting to be contacted. Contact tracing can be difficult. Someone who doesn't have stable home environment or poor transportation may have difficulty with isolating or quarantining. Seeking and receiving treatment may be difficult in this population. Preventing, because say possibly you're staying in a shelter and there are other people around you, and the ability to socially distance can be challenging. So those who have been doing okay maybe aren't doing so okay because of some of the pressures related to the pandemic, between economic issues where things were going okay and then they aren't going okay because people have lost jobs, or because of, even though there's supposed to be ways in which to keep people in their homes because of the pandemic, there may be some things people are experiencing stress-wise that just push them to the point where they're increasing their use, they've returned to use, they've had a relapse, or they're pretty consistent, they're using about the same amount, getting it from the same source, but then there's a disruption in their supply chain, a change in the purity of the substance that they're using, and then also a disruption in access to naloxone. So all of these things, secondary, thank goodness for that pandemic for just putting a wrench in everything, makes those living with substance use disorder, their challenges even more great. Next slide, please. Another thing that can be turned topsy-turvy is accessing care. One of the things that we've seen happening in our facilities is redeployment of services. So certain services aren't available anymore because our workforce has been delegated to other requirements. So you may have an ER that's not staffed quite the same way. They're really focusing on more of how to manage what's rolling through their doors with infectious disease concerns, as compared to what way are there and available to provide for individuals seeking access to care because of intoxication. Someone comes in as an emergency with an overdose, they'll certainly be taken care of for that, but maybe we don't have any beds available in the hospital to admit them because we've got the beds full of patients who have acute illnesses, or because certain sections of the hospital have been reappropriated because we need to enlarge our COVID ward, or offices are not open as much as they were, like reduction in capacity. We're only able to see so many people because we're keeping people out of the waiting room, or we're having to do visits in cars. You don't have someone who can come with you into the clinic, so you're less likely to come into the clinic because you can't bring your support person back into the room with you. So all of these things can certainly impact how people are able to, and if they're able to, access treatment. One of the nice things that's also not a nice thing, it's a lovely double-edged sword, is the ability to engage in telehealth services. That has certainly increased our ability to access certain patients at certain times, but we also work with individuals who don't always have a means to utilize that technology. So maybe they have a really old phone, or they don't even have a phone, they've lost the phone, or the phone they have, they can only text on, they can't do talk to anybody because they don't have minutes on the phone, or they don't have access to internet. So even though we do now have another arm with which we can reach out to our patients via telehealth platform, there's still some patients that's not readily available for them either. Next slide, please. So changes to treatment landscape, also because of the pandemic, we've been able to change the delivery system a little bit, where the need to come in and get your the takeaway doses of, say, your methamphetamine, Lord help me, your methadone, or your you go in and you're at a facility where they do observed administration of your buprenorphine. There's been a lot of change and backing off on those requirements so that we can increase the number of takeaway doses, have delivery services for people's medications so they don't have to come out of their home and come into a clinic. The increased use of depot buprenorphine. So instead of having to do small scripts where you're having to manage, like how much do you have access to? Are you staying stable? Are you doing okay? You get a single monthly dose of buprenorphine subcutaneously. Withdrawal management, trying to use our ambulatory services more. I kind of alluded to this a little bit more with someone maybe coming into the ER with an overdose or needing to go through withdrawal services. The potential for doing that in an ambulatory setting to decrease the number of admissions that we have. People in a residential facility. Residential facilities may have decreased the number of patients that they're able to have in their facility at any given time. Therefore, someone's ready, they need to withdraw, and being able, comfortable to provide those services as an ambulatory service instead of doing it as inpatient. And then above all else, emphasizing harm reduction. So making certain that we're even more liberal with handing out of the naloxone. Talking with our patients about, like, really tell me how you're using, because we need to make certain that what you're doing is safe, and I'll give you some alcohol wipes, or help and try and connect you to a syringe exchange program, or whatever it is that maybe we can do to help reduce the harm that our patients are experiencing with continued substance use. Next slide, please. So emerging data, next slide. This is just kind of fun. If you guys were on the last talk with Bill Brooks, where he was talking about epidemiology, he talked about the OD map. It's the Overdose Detection Mapping Application Program. So yeah, I am a sucker for tech. Sometimes I hate technology, except for when it's really cool, I kind of get sucked in. There's a lot of words there. Basically, I'll boil it down. So if you have this app on your phone, which none of us can get unless we're a first responder, basically like police, EMS, something like that. Those are the individuals who have access to this application. But say I'm an EMS provider and I've got this app on my phone and I got called to someone being found down and unresponsive, I can get on the app and put on information about, kind of where I was in town, whether we use naloxone, whether we were able to revive a person or not. So that goes in, and then the other side of it is you can actually go in and look at, if you have access, you can go in and look at data for your region and sort of see and anticipate, like there have been like a bunch of overdoses reported right in this little neighborhood, and this neighborhood, which I serve in, is adjacent to that neighborhood. I need to be more vigilant and paying attention. Maybe some of the calls that we're getting about people, being obtunded or whatever, like we need to make certain we've got our naloxone ready to go, having that more on the front of our minds as far as when we're coming into calls that we've received, emergency calls. If you can go ahead and hit the next slide, please, Brian. So if we had access, this level 2, so I'm in the field and I'm putting in the data, and it goes into the machine, and then I look on the back side of it and sort of like, what does that data look like? This is what it would look like if we had access to it. This is one of the few that actually is keeping track of non-fatal overdoses. Those slides that I showed you guys earlier with the graphs, those are all fatal overdoses. Our ability to capture like what is the number of non-fatal overdoses is not as good as being able to capture the fatal overdoses. And again, just how much of a picture are we getting of what's happening in our communities and our nation when it's the data that's easiest to get is the fatalities. So this is nice because you can see the little upper left corner. There's the red diamond, the yellow diamond, the circles, and all of that results in, fatal single dose naloxone overdose, non-fatal multiple dose naloxone, and you can kind of see how they populate around on the map. You can drill down by state and county, and then down in that corner, fatal versus naloxone overdoses, or overdoses naloxone was used. And then that total of overdoses, 8,700 compared to 1,000 were fatal, but look how many times naloxone was used, and you can definitely see the impact of having access to naloxone. Next slide, please. So they have all that great data, right? And I would love to be able to look at it real time. And Dr. Brooks showed this to us last time, this particular image. Luckily, the people who are gathering this data that we can't look at real time are producing reports and showing us, what does this look like? What are the trends looking like? When they first started doing this is there. So I think the graphs may be so so graphic, the change between January of 2019 and 2020. Yeah, I definitely think there's some COVID stuff happening there, but they may also have more data points to compare as more and more people are using this information. But those spike alerts is when you've had a significant increase in reported overdoses in an area. But this is really why this is here, is to demonstrate that we have had very significant increase in overdoses since COVID came to town. Next slide, please. So this is a bunch of words to basically say things I already said, but more than anything, that compilation of data for both fatal and non-fatal suspected overdoses, and then also seeing how many times people were actually using naloxone in the field, and if that resulted in a non-fatal or a fatal overdose. Next slide, please. So these are areas where people, like counties and municipalities, are engaging with that data. So you can see where it's happening. It's the gold counties where they are reporting, and then Tennessee is blown up there a little bit for us to see what we look like. West Tennessee is using this a lot. We do have some regions around us. So some of the data that we were just looking at, those numbers, those are our numbers, are contributing to those overall. Next slide, please. So one of the things that, you know, you can read other literature. I did not do an exhaustive to put it all up there because that would have been overwhelming for you and for me. All the data, like overdoses, are happening at a higher rate since, as I said, COVID came to town. And a lot of it we're seeing late winter, early spring. And 42 states did have stay-at-home orders, and most of those states are clustered right in the last 2 weeks of March. So it'll be interesting to see when that the overdose mapping people come back out with another report, because we've had several months now of COVID's definitely been with us, and we've had waxing and waning precautions and people staying at home and jobs lost, jobs gained, getting relief money, all that kind of stuff, how that's going to impact what people are experiencing. And those who are first responders collecting this data so that we have a very well-informed snapshot of what's happening around us. Next slide, please. So this is the fun part where we all get to be creative. So we know that we are in a situation where we have a lot going on, a lot to manage. We've seen studies and data that look like the overdose and use of substances is starting to level out a little bit, and then we have COVID, and we all know those numbers are just going right back up again. So how do we do something about the epidemic that we were just barely starting to get some traction on, if we're being very optimistic that we were starting to get some traction on, improve access to care, improving the quality of our care, and then we have a pandemic. So how do we manage in this very stressful situation to be effective for our patients who are dealing with an opioid use disorder or a stimulant use disorder or an alcohol use disorder during this very difficult and trying time? Next slide, please. So these are some thoughts on that. So vending machines as a way to distribute easily, like put in a token or a quarter or whatever it is, to get sterile syringes, a nice sterile cook kit, Narcan, teleconferencing and virtual meetings. So, group meetings aren't meeting in person most of the time now, but they are meeting virtually. So connecting to a support group, even though it might be through your phone or through your computer, having our visits virtually as well, spacing out our visit times, not requiring people to come in and do their daily dosing with methadone, changing the frequency of how we monitor. Next slide. So this is just a fun collage of like the vending machine idea. So it took me a long time to figure out what that was. Like, what kind of crazy caterpillar is that in that one vending machine over there? It's actually the name of the, and I can't remember what it is right now, but it's the name of the syringe exchange, I think might be what it is. That's what it says on there, and it's actually a syringe with the words written on the side of it. So it's like it's a syringe and clean cook kit and all that type of thing. A Sharps container is inside. So the picture in the middle is what's inside of that box. And then someone else's packaging for a vending machine to distribute safe needles, safe equipment, all that type of stuff. So now I am going to ask for your all's input on what innovative things you have seen happening in your region, in your clinics, in your hospital, or things that you would like to see done as far as being innovative for helping get people the care they need or helping them to engage in harm reduction strategies. And I'll just, if you want to advance one more, Brian, you guys can see my resources page and then we can close out. Woo, resources. I didn't make it all up, I promise. Okay, we can stop share. Oh, wait, this is a fun picture. Because I always put chickens in my stuff because chickens are my coping mechanism. And apparently this poor little boy needs chickens and cigarettes. So stressful time for all of us. For all I know, this was a picture from 1918 and they were dealing with Spanish influenza. So at any rate, I've forgotten to put that picture in there. All right, you guys, I want to hear from you. What innovative things are you guys seeing, doing? What would you like to be seeing or doing in your communities, in your clinics?
For one, I think that we could probably use a little bit more of the video conferencing, telehealth visits here. We did a few of them and we do some over the phone, but the telehealth itself hasn't exactly taken off, at least as Kingsport, as far as Kingsport goes. But I think that could be a good thing towards helping some of these people and providing a safer way for them to get care, not just for, we do primary care here too. So for that as well, there are some barriers definitely with getting our patients to do it. And maybe some better software might be available. What I've always thought we needed is just something where somebody can, where they get a call as if it was a phone call on their phone and all they do is hit accept. And, that's it. That's the video and that's you there. And some of the ways that we've done it, I think, are a little bit more complicated for us and for them. So maybe something that still needs work, but something I think that's probably underutilized, at least as far as our clinic goes.
Definitely. I hear you on that one, Jack. I chuckle because I know exactly what you're talking about because we use the same thing here as far as the telehealth platform. It can be a bit challenging on both sides of that virtual experience. Any other thoughts around innovation? Who wants to go get a vending machine and overhaul it and start putting syringes in it? Yeah, that was the coolest thing I ever saw when I was Googling that. That was fun to find pictures of that. I really don't know how that would fly in the state of Tennessee, I'll be perfectly honest, considering the fact that our health department can't participate. And that's what I'm used to is a syringe exchange through the health department, because that just makes sense to have it there. But barring us from being able to put syringes into a vending machine, they even had naloxone in that vending machine, one of them, which I also think is brilliant, and condoms, all kinds of good stuff in that one vending machine. Any other ideas about innovation, things that you guys have seen other places? Kafala's down there in Florida. Are you guys able to do anything a little more innovative or out of the box?
Not really. We're still doing tele-psych, for patients that come to the emergency department.
Okay, good. I'm glad you guys have the telepsych. Yeah, the vending machine, I don't know if both of them came out of Las Vegas, but one of them was a facility in Las Vegas. So just about anything goes apparently in Vegas. We do have a couple of other people joining us and I'll get them to introduce themselves here in just a second. Any other comments or questions about the presentation? All right, good. Estelle, I'm going to check in with you first and see if you were able to get your microphone working.
Dr. Troxler, are you referring to me? I apologize.
No, there's Estelle Velasquez. She's just unmuted. Well, we still can't hear. And I know she had sent a chat out, so I don't know if you and Brian were able to connect or not. Okay. Well, if you would like to type your information into chat, because at least that part seems to be working still. If you could just type in your information about where you're calling from and what your background is, how you came to join us, I would love to know more about you. So thank you though for being here today and hanging in there, even though we can't hear you, Estelle. I'm hoping you hear us well and you're not having any issues hearing us on your end or seeing what we're sharing. Angela Harless, if you can unmute and introduce, please.
Hi, my name's Angela Harless. I am one of the FNP residents. So pleasure to be here.
Yes, it's always nice to have you with us, Angela. Thank you for being here again. Marthinus, I may be saying that correctly. If you can unmute and introduce.
Hi, yes, it's Martinez, and last name is Zeman. I'm a faculty at the UT Addiction Medicine Clinic here in Memphis.
Awesome, great. We've had some other individuals from the program out there joining us. It's nice to have you with us. How long have you been on faculty out there?
Just about a little over a year now.
Okay, great. I know some of the people out there, so it's nice to have you joining us. Thank you for being here.
You're welcome, thank you.
Definitely. Simona, I'm gonna let you take a really big bite of food and then call on you to introduce yourself.
Hi, everyone. I'm Simona. I'm one of the addiction medicine fellows here at ETSU Family Medicine Clinic in Johnson City. And
Thank you, Simona. And
Hello, I'm Skylar Geller. I'm the other addiction fellow.
great. Thank you guys for joining us. I think they just finished up clinic shortly ago, so I'm glad they could join us. All right. Brian, do you have Carvalho's case?
Yes.
Okay, perfect.
Yeah, actually, I actually got it modified. I have a different, but